Hi folks, Pierre-Yves GEOFFARD, member of the Cercle des économistes. Welcome to this session. We're going to talk about care, organization and financing of care, healthcare. So we have around us a very nice panel, quite diversified. Mireille will introduce everybody to us in a few minutes. We're going to take advantage of this diversity to cover a lot of topics, but there's so many questions that are raised here. We're going to talk about access to care, important topic. We talk a lot about the rupture access on drugs, medication, ordinary medication, very important, sometimes old drugs, but is the answer to relocalize the production? Should we relocalize the production of certain steps of the production chain which are produced elsewhere? Problem of tariffs, tarification, cost, prices. Should make a distinguish between mature, innovative, and old medication. Is the access to innovative medication as good as it should be or as it could be? To that extent, are the problems related to costs and tariffs? We have an access system to innovative drugs which is complex in France, with sometimes lead times to access the official market which is longer than in certain countries, but with an access with early access which does take care of some of the issues. These are the topics that we will cover. We talk about innovation. Innovation is not only on drugs, but there are a lot of innovation on drugs. In the later years, we have a wealth, a richness of the new medication that really cure pathologies that we couldn't address 5 or 10 years ago. But it's not only medication and drugs, but there's also the organizational change, which is the challenges with AI and the avalanche of data, which can be useful to think better of the care system, data that is not always accessible to all the operators, that could use them to improve their practices for the service of the general interest. And in the organizational evolution, there is the organization of care with here challenges and that are numerous, the development of chronic pathologies, the articulation between the hospital and city doctors, for example, with the evolution of medication and drugs. But we also have organizational evolution with development of healthcare centers, reflections on the organization of the different healthcare professionals. Talk about the articulation of healthcare professionals rather than talking about delegation of tasks and not have this top-down approach. So I don't like monopolies. And that's where the challenges are. We see that there are some people have the cold feet when it comes to accept the improvement of competencies, skills, and advanced practices. It's not just we see that these are challenges, but we know the solutions have to be sought. Innovation is also concerns financing. It's something that we often leave aside. But in France, we have a system that is quite original. It's a two-tier system with the public insurance and the mutualist insurance. Do we really reap all the benefits? Do we really use the potential benefits of this organization, public-private, that could bring forth more flexibility, more agility in the system? A system that really needs more flexibility. So we'll talk about the articulation between Social Security and mutualist insurance, and two topics that are often very constraining when we think of better efficiency of the care system is the principle that care expenditures are annualized, especially for Social Security. So we always think that it's an annual planning while the stakes are pluriannual if we talk about the care for chronic diseases and things, and the silo type of financing. We have an envelope for the hospitals, an envelope for this and that, and it's an hindrance to flexibility and agility and to efficiency at the service of guaranteed access to health for all. So nice introduction, Eric. Thank you. I'm Mireille WEINBERG. I'm Chief Editor at Capital. And I'd like to introduce you to our panel. To my right, Eric Nomi, who is the President of April. Let's say, ensure you supply services to other insurance companies. A lot of people use your services in 20 countries. Eric, you are more a legal specialist in the field of insurance, but you've really climbed up the ladder and you're now holding management positions. And next to Eric, we have Eric CHENUT, the president of the Fédération Nationale de la Mutualité Française, so the French mutualist insurers, the administrators of the Vive and Gen groups, which are really very big mutual insurance groups. You're involved in that sector for 25 years, and you also held the leading position in for physically disabled people. You know that the mutualist insurance are funders, financiers, so they reimburse the health care, but they're also health operators because they have health centers that they manage, you know, health centers, hospitals. And next to Monsieur CHENUT, we have Sophie BOISSARD. Sophie BOISSARD, you're the General Manager of the Clariane Group, Normalienne, and you did the ENA school. You've held positions at the State Council, the Ministry of Labor in Bercy, and for 10 years now you have been at Clariane. Clariane is an essential actor in the healthcare system, 666 retirement homes, pension, 517 health centers specialized in mental care and rehabilitation care. Next to Sophie, we have Olivier, the president of the Servier group. Monsieur LAUREAU, you joined the Servier group, which is governed by a foundation in 1982. You climbed up the ladder, you began at the legal department, and you're now the CEO, president of the Servier group. You're also a member of the G5. It's the grouping of the largest French laboratories. You take part in all the European instances, international relative to drugs and medications. Servier is one of our largest pharmaceutical laboratories. You're a leader in hypertension or rare cancer. Laurence, Madame Pierre-Yves, the director of the LEEM, Federation of the drug industry. You have experience in bank, insurance, agro-food business. You spent some time at Roche, and now you're the general manager of the LEEM, in charge of representing the French laboratories. And that's all. This is it. I will address my first question to Mrs. PEYRAUT. Now, in terms of sanitary sovereignty, 75% of the molecules are produced elsewhere in the world. The French discovered that during COVID, and the second quarter of 2020, India decided to close its borders and it stopped exporting its molecule of paracetamol, aspirin, and there was a shortage the world over. And we realized a lot of things were manufactured in India and China. And so we have to reconquer our independence and sanitary sovereignty. How, since COVID, we managed to change things to that effect? Thank you for your presence. Good question. When we look at, since the COVID, where at that time we all said, you know, the state and companies, we had to rethink our sovereignty. for all the strategic sectors. So for 4 years later, the Rencontres d'Aix are on the topic of shock of realities, on the policies of health and medication in general. We haven't any planning laws to that effect, while in Europe, and for reasons we know, we are capable at the European level to give more thought on cooperation to defense, for defense. But in terms of drugs and medication, I represent 300 very nice companies, sometimes small companies that produce the oldest products to the largest international groups which work on innovative products. We have very different interests, but very much converging, because we have, and it's our reason of being, we need to ensure you, French people, French citizens, and elsewhere in the world, that all patients get the proper treatment. And it's a challenge. Your question on sanitary sovereignty, there are more than, will we be able tomorrow to relocate the whole production in France and Europe? Yes or no? No. Okay, do we want that? No. But developing cooperation and reflecting on strategies to see where are the medications that are the most critical. We need a programming law to make. We need to make choices, and we appeal to the government and the president. They consider us as one of the strategic sectors of France to work on the future legislation. The good news is that we were able, thanks to collective intelligence with all the laboratories committed and the Drug Security Agency, after the shortages, we can say that today we've gone back to a situation prior to COVID, so we're now at an acceptable level, even though there are certain therapies that are under tension. Why? Because there is a fragility of the production system, and I will conclude there to say that there are 3 ways of addressing this. We're not here to complain. We're here to think of how we can work differently together. If we continue the same as we did in the past, we'll have the same result. We know there's a big topic on the competitiveness of France. It's a question of attractiveness in terms of health. So we have to encourage companies to invest in France, convince them that they should invest in France. A figure that struck me when there were the U.S. announcements. They announced 250 million euros in the U.S., which is the priority market. So how do we really give the will to reinvest in France while these billion euros are invested in the U.S.? So it's a real issue of competitiveness. And second point, we need to invest in research and production. Another figure that I would like to mention, when you zoom out of France, in Europe, 20% of the clinical trials are done in Europe, 80% in the US and Asia. Why it's an issue, why it's a challenge at stake to recover innovation is what you invest in clinical research, you invest in the hospital, you invest in the territories, and you invest in the production system. So it's a major stake to rethink, to review research and production are very linked. And the third point for this first part, there's the question of methods. France has deficits, we know, the debt level we know. We have to be able to work in closer collaboration with private and public sectors. They shouldn't be considered as enemies. It should be sectors of activities that are working together. In terms of efficiency, we make a lot of propositions that cost nothing for the patients and nothing to the state and enterprises. It's a win-win-win situation. That's why we decided to start working on contracts, because this method will give us the necessary leeway and breadth. Mr. LEUREAU, you serve an international group. How do you how do you implement this sanitary sovereignty? And do you think that this, we understood what Mrs. Pierre-Yves said, it's not a national cause. How can we organize things in Europe? Well, first of all, I would like to talk about a few facts and then go back on the principles. A few pharmaceutical groups, among which are the leaders, have a turnover of 3 to 5% in France, and so the rest of their income is 95% internationally. We generate 33% and 97% abroad. But we create value in France through research, production of active elements. So these are figures, and as Laurence just mentioned, I think we have to work on the long run. What characterizes the industry of medication and drugs? It's a highly capitalistic industry. We will invest significant amounts of money before a drug is made available to the patients. For 10,000 projects we will have one that is successful. And the cost is between 1 and 10 billion euros, depending on the therapeutic domain. So the predictability is really essential today. The health budget are voted on an annual basis. They evolve. I'm thinking about special tax incentives, and the pharmaceutical industry is the industrial sector that has the highest sectorial taxation. In Europe, it's very high. So we need to have more predictability because we're working on long cycles. Our industry is very, very highly controlled, and it's an industry that's at risk because it can be that at the end of our development studies we decide not to launch the product on the market because the benefit-risk results are not good. So a lot of parameters that explain this will to have this long-term vision. On sovereignty now, we have 3 strong pillars, whichever country you're in, which give rise to a very harsh competition. So there's no multicultural, bilateralism, multilateralism, so innovation. It relies on simple parameters. To innovate, you need talent and extremely attractive, innovative clusters with passionate projects, attracting people from the world over. We have 22 different nationalities in Cercle, in our research center, people coming from the world over. The richness of this diversity is at the source of our innovation. But you need strong clusters, not too many, otherwise we will lose our attractiveness. Look at what's happening in the US. Boston, San Francisco, a bit New York, but if you go to China, you have Shanghai and a bit in Beijing. Very few clusters, but extremely strong clusters to attract talents. That's the first thing. The second thing is you need to you have to like taking risks. I think we've lost this this taste for risks. I'm thinking of all the biotechs, which when they pass the Series A, they leave Europe because they're not accompanied financially. So the financing must be there in Europe if you want good biotechs, if you want patents in Europe, innovation in Europe, for patients in Europe, for the sovereignty of Europe. So for this, the financing has to be accompanied with tax incentives, risk incentives. The third thing that's very important on innovation, it's the speed. The speed will be based on AI more and more. And I will, of course, answer your questions if you have. We have to be faster in our selection of projects, faster in development. Concrete example, when you carry out a study, clinical study, you have to identify the patients and the health centers that have the best profile. And for this, AI would be perfect. So this is for innovation. The second side is industrialization. Do you build a plant when you launch a drug? It has to be built 5, 10 years before. You need the talent for that. It's a risk that you have to take, and we take it. And I said earlier, we shouldn't have the pretension, I think in France or in Europe, to master the 100% of the production of active elements and finished products. Just for reasons of cost, it's impossible because we're not working under the same standards and same regulations. I would say that between France, for a same company, for a same volume, and Poland, between France and Poland, I have differences that are between up to 73% in Poland. Why? The number of hours in Poland is much higher and the hourly rate is lower. And that's a simple reason, access. Also, we'll go back on that later, but you have to go fast, you have to be faster in validating the studies, faster in analyzing the refunding, and rapidity, speed is a key for sovereignty. Innovation, industrialization, fast access, and also served more and more by AI. Thank you.
Thank you, Sophie BOISSARD. We're talking about the deficiency of our healthcare system. We can see that there's some issues, definitely. What do you think about this question of management of AI and big data? Is that going to make it possible to relaunch our system? Well, thank you. First of all, I'd just like to, in continuance with what's just been said, explain some of the healthcare challenges in front of us. Thanks to the real advances, phenomenal advances in terms of research and treatment, combined with amazing advances in terms of miniaturization linked to operations and heart surgery, for example, joint surgery. So today we really have a capacity to heal or stabilize pathologies that used to be mortal. What we're seeing in terms of progress with cancer is really remarkable in terms of immunotherapy. So this is excellent news, and it means that we are going to see life expectancy expanded. And we've managed to see a growth in 50% of life expectancy since the Second World War. And so this leads to longevity and aging. And so the era we are in today is the era of chronic diseases. That means we have situations which require really acute specialized treatment in specialist centers that can diagnose and offer treatments, and then can monitor at home, or at least as close as possible to the place that people live for a long period of time throughout the lifetime of the patient. And when we look at statistics today, 80% of people over 60 have a chronic pathology, in the sense they take a long-term treatment. And so the issue, and a high percentage also take 2 of these treatments. So the question is, how can we bring these things together with these centers, with specialist centers, working with the best of research and the best of pharmaceutical production, and also networks, healthcare networks, as close as possible to where people live, with these issues around general practitioners today in France who are working with, and a lot of older people in France today don't have access to these general practitioners. So we have this kind of 2 worlds where we can do amazing things, and at the same time basic treatment to a doctor who's going to make sure that you're generally doing okay and who can communicate with a specialist. This is becoming the prime concern of French people. And so really what we're trying to do is to see how we can put in place a network across France of healthcare centers with doctors, but particularly nurses, specialist nurses, who can offer this support alongside hospitals or hospital centers which have prescribed a particular drug and which offers a backup. And so in answer to to answer your question, Mireille, through telemedicine, we can transfer data in a technical way very simply, and we can do a lot more things through outpatient care than before. So today you can have a hip replacement and you can go home the same day and get support from your GP team and your local care team, or other areas that require really complex treatment. And sometimes the miniaturization is making it possible to offer treatment. So clinical and physiotherapy options are really making a significant difference. The other really important issue is what we're discovering today about prevention of significant dependency. There's a center in Toulouse in France focused on aging, and there's a center working on understanding aging, and they're starting to show that with if you mobilize capacities early enough and enough in terms of locomotive capacities of patients, we can help people to have these capacities reestablished and help them to live well up to a late age. And so we need to detect the risks of fragility and future incapacity and put in place physiotherapy, which is not and rehabilitation systems which don't involve drugs but help people to gain in quality of life. And so this deep shift between a medical approach that was focused on infections, really significant surgery, and moving from that to a distributed type of surgery with healthcare professionals working as close as possible to where people live. This is technically possible, but at an organizational level, it really is a Copernican revolution. It means not just a single professional that you're working with, but working with a team. It means sharing data over a long period of time. We have GDPR issues, of course, with that. And we also need to train all healthcare professionals in this new approach. And we also need to have more professionals than we have today. Not more doctors, but nurses, rehabilitation professionals. Today in France, we don't have enough of these specialists. Thank you very much. Mr. CHENUT, it's almost the same question for you. What kind of oil do we need to put into the healthcare system for it to work? And can innovation help us here, or is it not going to be enough? Good afternoon, everybody. Well, innovation will be part of the solutions to ensure the sustainability of our model at a worldwide level. This is essential because a whole number of public health issues are planetary or even just at a European level. And given that the US has withdrawn from the WHO and changes in worldwide governance around healthcare, there's a number of issues. And it's important that at the global level with the different agencies and also at the European level, we develop a number of different issues. And at the national level, this has been said already with this duality between the Social Security system, which is celebrating its 75th anniversary in France this year. We've talked about the importance of aging. This is a significant transition that's going on. The expenses on treatment of people over 75 are 4 times the amount of someone who is 50. But between now and 2050, we're going to see a massive increase in this layer of the population. And we're not training enough doctors today. We're not training enough healthcare professionals. And so if we keep working in the same way that we were working 30 or 40 years ago, we're just going to be managing lack, dissatisfaction, fear, and resentment. And so we need to offer support for chronic pathologies. In order to do this, we need to change the way that we work. There's an awful lot of experiments being done today. A lot of talent is being poured into the organization of the way we offer treatment, being carried out by mutual insurance companies, startups, and different players. But the challenge that we have is that we're really struggling to scale this up in terms of the challenges around assessment and setting directions for public health. We are all expecting players in the sector to publish the strategic directions, and we've been waiting for this since 2023, and we've been waiting for this document for 2 years. We've not had any priorities fixed in this area for 2 years now. So the issue of this deficiency, which is in front of us, the issue of prevention policies that need to be put in place, working across the French territory is really important. All of these issues are blocked at the minute. Laurence mentioned this earlier. Given the fact that we're locked into the budgetary annual approach, but we're not moving forward, and this is a loss of opportunity for our system. In terms of efficiency, we recommend today that if we want to have more shared skills between doctors and paramedical services, and we're going to have to move from local doctors to teams with a whole number of different specialists, including pharmacists and nurses, and we're going to need to share information about patients. This means that we need to give tools to these professionals. We have My Healthcare Space, which is the key data sharing area that exists in France today. We still need to see a development in the legal framework in terms of sharing competencies, but we need to go into a confident approach in terms of data use. We need to make it possible for all actors. If we want to really make an impact, we need local officials, local elected officials need to be able to have access to anonymized data if we want to drive forward key political policies so that we get ahead of public policies on housing, urban planning, infrastructure, etc. Everything that will make sure that people stay in good health as long as possible. 2/3 of health determinants are from outside the healthcare system. So we really need to maintain an approach that is not focused on a cure rather than prevention. And we really need to avoid maintaining that. We need to change and move to prevention rather than cure. What most European countries are doing faced with GDPR and data, of course, we need to fully comply with the GDPR, but other countries are making it possible to use data in order to put in place treatment pathways in a participatory, personalized and proactive way. And that's something that's really lacking today in our country. If we want to manage risk for social security and mutual insurance schemes, we really need to make it possible for people to handle their own healthcare pathway and help them to stay healthy as long as possible. We really do need to ensure that we put this in place. This is absolutely key. And the last aspect is that today there is bad spending. We are spending on redundant treatments that are inadequate, that are not given at the right time. So that means we need to have a better organization by bringing together professionals, by using data to prevent that we don't have redundant repeats of tests that have already been done or scans that have already been done. We are prescribing more drugs than average European countries. This is not useful, and there's a risk, and actually it leads to the hospitalization of a quarter of older people, and also leads to some deaths. And we need to improve the professional skills of all players in the healthcare sector, because we have a number of actors who are often funded by shareholders from outside France, and we need to avoid this happening and avoid them capturing the value. Thank you, Mr. CHENUT. So I want to hand over to Eric MAUMY. You are an insurance broker, but you also have experience with the healthcare system. You are struggling to be close to the heart of the system, but you're operating in a number of different countries, and you're working with healthcare systems in other countries. Tell us how you see the deficiencies in the healthcare system in France. Are there things that we could do that we could make it more effective and efficient? Easy things that we could do, yes, but not necessarily in France. So Eric CHENUT was just saying that the role of mutual insurance schemes is not to be a funder. Unfortunately, we're really limited. We are a funder, but we are kind of a blind funder, as it were. So this capacity to absorb, our capacity to absorb innovation is really very low. We say this very simply. The social security deficit is around 16 billion at the moment and is rising. So mutual insurance schemes have the requirement to have a zero balance. So how do we balance this out? And sometimes this works in France. So a good example would be the healthcare networks that you were referring to, particularly around optical care and opticians. Why did this work? Because we set ourselves very clear objectives of taking care of patients. And here we don't just mean a question of access to healthcare, but high quality healthcare. So we have networks where they're working on taking into account optical care. And then the second thing is that we've been given the latitude to go and put in place contracts with healthcare professionals, opticians in this case. Unfortunately, this is just an exception because we really are very limited by the LEEM law in France and also by a suspicion around mutual insurance schemes, where there's a whole number of really valuable and interesting examples in other countries. So in other countries, there are some differentiated guarantees. So I can say to you that I will, for example, your hip replacement, your tooth replacement, I will, the insurance company will say that I will reimburse you more if you go and see your dentist every year. That's a really valuable thing. The second very, very valuable lesson that we can see from elsewhere. So in terms of surgery in the case of morbid obesity, so surgeons come to reduce what needs to be reduced. And we see that if we do this surgery, if we just do that surgery over 18 months to 2 years, 50% of patients fall back into the same situation and they go back to the same healthcare, the same weight that they were in before. However, if we put in place a support with psychologists, with dietitians who make sure that there's not a reoccurrence of the obesity. The third example is really very interesting in some English-speaking countries, such as the UK, Canada, and Australia. So these are support for feared pathologies such as rare aggressive cancers. And so here we have guarantees that is to do with prevention, and the insurer will come and say, I will provide you with capital, will organize the healthcare treatment, organizes the access to the best hospitals and high-tech solutions, and the insurer will also be involved in supporting the patient in order to get care at the right place. In France, we are not in this situation. Everything is in the hands of the state. And actually, it would be really very simple to unblock the system. You can see that insurers know how to manage risks, just like they know how to manage the accounts. Thank you very much, Eric. Mr. LAUREAU. Everyone, let's go backwards a little bit. Everyone's been talking about AI and data. In your industry, your pharmaceutical industry, how important is this, and how can you adapt this to create efficiency?
An example, to go back on what was said earlier, when it comes to accompanying the patients in Germany, our product that is in the field of mental depression, we developed a computer solution that is validated clinically that will enable a patient to recover all its cognitive sense, its relation to the others. The mutual insurance purchased by this solution because in their interest, the patient will no longer at home, he will be back to work, and the mutual won't have to take charge of him. And so I fully agree that there be a change in the law with the mutualist insurances so that they can intervene via the doctor or on the patient with solutions that enable to shorten the treatment period. And artificial intelligence, well, inside Servier, the group, we've made a giant leap to be best in class. We're not far from getting there. So what does this boil down to concretely? First, significant investments on research to be able to either pursue a program or stop it. When I talk about research, that's even before we're in the clinical phases. Sometimes we're before the proof of concept, very much upstream. We need a lot of data available worldwide. The more we have AI, the more we have access to this data, which means that there's more openness to the access to data, public-private. You can purchase the data, which is not done in France. In France, we don't share data. We have to look for it in the US or in English-speaking countries where the sharing data is accustomed. And with the Association of Patients, we can find the data there. It enables us to go faster, and the arbitration we have to make, decisions we have to make in our research programs upstream. So thanks to AI, we're capable to do that. You have examples of things we've discovered that were not intuitive, that we discovered with data, on the basis of data? We were in Boston with our teams, and I asked the question, I said, is there one drug that was discovered thanks to AI? And no, there are no drugs that were developed, but it enables to accelerate the programs and make the right choices. And maybe in the future we'll find drugs generated by AI. And development. When you're on clinical studies, multi-centric studies, when you a lot of hospital centers worldwide that are involved, what's important to go fast is to identify the patient that corresponds to your protocol. Example. We launched on the market, made available to the patients, a medication, a drug in the field of gliomes with mutations. So we needed to identify those patients. There's no necessary prevalence that is monitored. So thanks to AI, we've identified the patients, the centers, and go a lot faster with a lot of relevance. And third use of the artificial intelligence is that we improve the production efficiency. The evolution of markets is such today, and with our cycles, we have a certain number of active elements, and the time of synthesis is 6 months. Production time is 2 months. So we have urgent orders. You have to be extremely reactive, and so the alliance, production, AI, enable us to model forecast systems and to respond. So these are the 3 sectors in which we use AI. Of course, there are a lot of other fields where we're going to use AI to maintain our position as best in class worldwide. Sophie Boissard, you were talking about the deficit of Social Security back in Franco-French context. So you did a study. It's your job, in fact. Aging is one of your specialty. It's your job to work on aging populations. You looked at the cost of this aging of the populations. Can you talk to us about this study and how you intend to implement things to avoid that it gets out of hand? So we carried out a study by looking at what is the share in health expenditures in France by slot of populations. And this study, by transposing the evolution of French demography and studying the behaviors, over 10 years, we think that we should double the deficit of 16 billion. 16 additional billion, which is the mechanical transposition of what Eric was talking about. That is, a patient over 75 years of age will consume 4 times more than a 30-year patient. It's a mechanical evolution. So once this said, one of the specificity of French spendings, Clariane were in 6 European countries, in Spain, Netherlands, Italy, France, the same kind of activity. That is accompanying, taking charge of chronic or aging people in health care centers or at home. And if I take the way the Netherlands are organized, they chose, based on this observation, that they chose to transfer part of the care on proximity centers. You know, medicalized retirement homes, and they preventing the access of preventing having too many aging people at the emergency wards of the hospitals. You know, one day at the hospital costs €1,000, and care spending we will pay is €50 per day. In the Netherlands, it's €250, so you see the difference. But €250 is a lot less than 1,000 that you pay in hospitals, a day in hospital. So this strategy consists in saying, I strengthen the system and to stay as close as possible to the home of the patients, and by using trained carers who can rely on the hospital structures to benefit from their expertise and have the recommendation, maintain the dialogue with experts, but they manage those nurses and things to stop this evolution. And we think, when we look at the studies, there's some in-depth studies that were done by the Ministry of Social Affairs, by the Haute Autorité de Santé. These studies show that today 40% of the hospital spendings concern people over 75 years of age. 40% in the hospital spendings represent half of the health spendings in France, so it's very high. Very important share. And the estimate we did today is that 10% of the hospital days, those consisting in sending to the emergency wards an aging person because there's no general practitioners or no other ways to solve the problem. It represents 10% of hospital days, and we all know, for having been faced with families or whatever, going to the emergency is not the best, the optimal solution, nor for the patient or for the system. So in the question of efficiency that you raised, Mireille, we have to address this question, how we strengthen this proximity offer by using trained professionals specialized in that sector, and how we remove the load from the hospitals so that they concentrate on what it's best to do, that is this taking charge, high-level charge. Thank you, Sophie. Mr. CHENUT, we mentioned the role of mutualist insurances, which is marginal. We could do more. Everybody seems to agree to work hand in hand. And you, from your standpoint, what do you think we could do? What could you do easily to improve all this? Well, the public authorities need to stop deciding in our place and let us do our job. Eric earlier said, gave a number of examples on what the complementary and mutual insurance can do. If the role of mutual insurances is just to boils down to co-financing or cover for the incapacities of Social Security, but there's no added value. But we do a lot better, and notably play the role of increasing the responsibility of social services, the better use of the health system, and go to the right professional at the right moment. It presupposes a lot of pedagogy, and it presupposes to help people to understand what are the right recommendations in terms of public health. We know today, we see in the US, but also here, the people are skeptical on vaccinations, the questioning of scientific facts, solid things that are solid. There's research behind that, but some today put at the same level scientific facts and opinions, which is very negative for the health systems and for democracy, in fact. And here we have a role to play. And there's a challenge on stake also for health professionals. I insist on that. Can we continue sustainably to have today a total freedom for prescription drugs, not taking into account the recommendation of the Health Authority, standards of the taking charge, determined by College of Experts, scientists, doctors. What justifies diabetes being not been taken charge of the same way in Aix-en-Provence or Paris? Nothing, depending on how trained the doctor is and if there was a medical follow-up. So we can't afford today to continue that way. But there are also the issue of responsibility, you know, how much it costs. With the generalization, the full coverage, the prescribers, patients, we lose sight of how much it actually costs because it's covered by Social Security. How much an X-ray costs, how much a day in hospital costs. So there's a stake here of responsibility if you want to do the right choices. Reorganizing the territory. Reallocating the right competences in the right places and weave this trust between the patient and the actors of the healthcare system. So it's adding responsibility and trust in the actors. If we don't do that, we're heading for major difficulties and probably it will affect the trust in our care system. So we hope that the Social Security will continue to do things we don't know how to do, that the mutualist insurances will do things that the Social Security can't do, and that we can work together in trust with the drug industry on the proper use of medication and drugs, with health professionals to do their job, with social structures to structure the paths from housing to retirement homes to the end-of-life centers, and manage to really personalize, customize the services so that people which are disabled can be served. So it means that there's more trust between the different actors, and that's what's lacking in our country. Just an example. In Sweden, same GRDP that we have, dentist, for example, who welcomes a patient over 7 years of age with a dental problem of some sort. He knows that this dental problem will lead to a problem of masticating, loss of muscular mass, for bad ingestion of food, and so there's a change, and so the person is then sent to a therapist. You know, here we don't handle that. We wait for the person to fall. I think we have to steer clear from that, and we have to trust each other, create the conditions so that people no longer stay in good health, I'm sorry, and make sure that everybody contributes for the general interest. Eric, aren't you under the impression, you know, I read the load-in products, I don't know, charging products of social insurance is the first act to establish a budget of Social Security every year. In this report, we're under the impression that the public authorities want us to be involved, the mutualist that is. Well, there's a consensus on non-essential things, like the responsible contract with the legislator covered, you know, the level of guarantees. No, the real topic is not there. That's not the issue. And Sophie addressed that. That's in the dead angle of public policies, and that is prevention. To be simple, we talked about Sweden, France at 65. I think it's 50%. 55% of the population is good at 65. Sweden is 20 points over that. If we take the WHO, they have precise indicators on vaccination against papillomavirus, against the flu, the tracking different cancers. All these topics, well, the mutualist insurance can be wonderful relays with the patients because we are in contact with the patients. We do prevention on muscle and skeleton problems. So we have a huge topic with prevention. Santé Publique France estimates that at the scale of 10 years, we can save 15 billion euros of savings by implementing prevention measures, 5 billion on chronic disease, obesity. We mentioned obesity earlier, diabetes. We're victims in France of what we call the problems with diagnosis. In other countries, I have a lot of examples where the diagnosis is done much faster. You talked about high blood pressure and the follow-up. We have 2 billion on cancer with the early tracking. We can talk about tobacco. We can talk about vaccination with people refuse to be vaccinated. Mutualist companies have a wonderful reputation before the patients, and it's up to the public authorities to simply create the conditions. And believe me, the mutualists, insurances push for that. It's not something that's done in solo. It's a complementary work. We have 15 billion of savings we could generate in 10 years. So it's a wonderful conclusion. Maybe one or two questions from the floor, if there are any. Lajoignine. I'm an inventor involved in humanitarian work. I run a company. My question is simple. I think health is very sick. I think we need to cure it. Don't you think it's time, more than time, to have a revolution, a Marshall Plan? To respond to very simple questions, how can have a taking charge that's adequate, and to ensure that everywhere there's well-being and that we age comfortably? Thank you for this question. I have a proposition to make. More than the revolution, which often doesn't really work very well. So we're actors that are very responsible. I was in Denmark some time ago. They created an incredible committee, which is called the Life Science Council. It's a public-private organization that brings together both actors. They have they take one decision, and the only compass they have is to make sure that it's good for the patient, for everybody. So we need to really have Copernican revolution, because today public and private sector find it hard to work together. I think it's an accident. Before trying to find to make economy savings that will hurt everybody, I think we can find the right solution by working together. Thank you very much. You can ask your questions. If you have questions, you can ask them to the panelists outside this room. Thank you.